So what is mathematical modelling? I've spoken about it and I'm not going to define it particularly in technical detail, but really there are two options, two use cases for mathematical modelling in my mind, and I'll let other speakers say if they disagree or agree with this in their sort of talks. But really we have a preparedness role and we have a response role. So for preparedness, we are sort of thinking of a scenario, what happens if smallpox was released or plague or something. We build a model, do some contingency planning, risk assess, and then we could even use that to frame exercises. So we've just been through a national exercise planning for a future pandemic over the last couple of months. So we can use that to frame the exercises and look at sort of gaps in evidence and things. Or we have a response role where we're trying to do real-time modelling, which is what we'll be touching on today, and giving expert advice and sort of visualisation for those tools. Now in peacetime, which is a phrase that may or may not be useful when we're not in a pandemic mode, we have a fairly simple virtuous circle for delivering modelling advice. We will do a literature review, we will create a model, integrate that with the data, interpret the results, and then use that to inform policy. Find that we've made some horrific assumptions at some point, or that we need to get millions of pounds from somewhere to do a research study to get some data, and then go back through that loop. And thus we're always employed and we never have to deliver anything. In a pandemic, that virtuous circle breaks down because we have a week to knock out some evidence or knock out a report. So you can't do the loop back. So it's more, you're sort of doing some work and informing policy and then moving on to the next challenge. And I think that's important to sort of keep in mind. SAGE operates in a number of ways depending on the emergency. So SAGE is a scientific advice group in emergencies. That is stood up by COBRA, reports to COBRA. The chair of SAGE, or the chairs of SAGE, will report to COBRA. In an emergency, this could be any emergency, and SAGE could be any expert. And I, in my previous job at Public Health England, UKHSA now, I engaged with SAGE a little bit in various ways, mostly on exercises. But occasionally as a duty officer in emergency response when there was bad weather, flooding and things. But for the pandemic, this was set up as a series of core subgroups and then task and finish groups. So, and I think it's just worth setting the scene, spending a few minutes setting the scene on this, because these four groups exist outside of the pandemic space. So they're not, so we have NervTag, that's an independent group that's looking at the virology and epidemiology of emerging viruses, respiratory viruses. We have SPI-M, that is the modelling advisory group. We have SPI-B, that's the behavioural science group. And these exist outside of pandemic space. They are, so all three of these are, it gets a bit complicated, you don't really need to know the full backstory to how exactly these exist and got set up in the first place, but they have a life of their own. But once SAGE is set up, they pivot to an operational mode that reports into SAGE. And they're giving discipline-specific advice. So you can already see that this is a little bit potentially siloed. Virologists, modelers, and behavioural scientists. And then in the pandemic, they realised that they needed another expert group, which was more engineering focused. And so Kath Noakes led, well, HSE and Kath Noakes led on that. But then, having got these sort of almost silo-based sort of discipline, we realised that we needed these cross-cutting themes, these specific themes, and so these task and finish groups were set up. And the care home working group, we convened in April 2020. It was sold to me as a task and finish group, and then 2 years later, on April Fool's Day 2022, we stood down, because that's when Sage stood down. So yeah, it was a job for 2 years. It was an interdisciplinary group, but because we've been doing some work through March, I was sort of invited. I hadn't done any social care work before. That's just important. I'm not an expert in social care. I am an expert in developing models for settings and things. So yeah, we looked at that. So what did Social Care Working Group do? Or Care Home Working Group, it changed its name a little bit through the pandemic. Well, we wrote 7 or 8 Sage briefing notes. So these are in the public domain, they have fancy code numbers, they're on gut.gov. The first one in May was basically saying why we couldn't do modelling. We didn't know any information about contact rates inside the settings. We had very little surveillance data, and so without those two things, we can't really effectively model, and we were using sort of cruder models for doing some of this. And then there are sort of some various important things like the visitor policy, work, currently what's going on, what mitigations are can be deployed post-vaccination, and whether shielding would be an effective strategy. So there are various things there. And the hospital discharge paper, which isn't on that list, unless I can't see it, became, I mean, from the inquiry, and we'll probably explore the inquiry after the research talks. The hospital discharges into care homes became the main focus of the inquiry. So one of the early things we did was start to think about the hazard for care homes. And this isn't rocket science necessarily, it's sort of common sense when you think about it. But these settings, and it translates across to prisons as well, these settings have an ingress chance, there's a chance of the disease being imported, there's a transmission hazard once it's in because of close contact, and then there's a density of people, so you have an outbreak hazard, and then you've got a frail population, so there's severe outcomes potentially. And if you think about interventions, this is why interventions are a complex space. Those 4 hazards, interventions are really focused on only one of those issues, hazards. The only one that really cuts across all of them is vaccination. And that's why once we had vaccination, that's a bit of a game changer, because vaccination could reduce the impact of the disease if someone's infected. It reduces transmission, and by reducing transmission in the community, reduce the ingress risk. So vaccination is a game changer. Otherwise, you are having a very complex intervention space, and that makes it quite hard to model. The unintended consequences of those interventions. So in some senses, respiratory diseases need some sort of contact between people. So if you just lock everyone up and stop them moving, mixing, you stop the disease transmission. Which is, okay, we went through a national lockdown, and that, we sort of we've all lived through that. But in these settings, in care homes, if you stop visitors coming in, there's a well-being impact on people. They're not seeing family, you're not seeing their loved ones, and possibly at the end of life, and so on. So we started to look at the balance of harms, and we we were worried that this was going to be an emotive and quite difficult, challenging problem. But Alex Thompson from the University Health Economics team managed to start finding some evidence of the impact on well-being. And we started to realise, even with the profound impacts and case fatality rate, which we'll talk about on the next slide, of people who do suffer from COVID, the outbreaks that are possibly outweighed by the wider mental health impacts of the interventions. And there are tools like ASCOT, and we need to do a lot of research to integrate these with our epidemic models to build for the future. So this is an area of active research. We've got a grant application under review at the moment, so hopefully in the next few weeks before Christmas we'll hear if we're successful there to really sort of tackle some of this. The case fatality ratio is an interesting pattern as well. Ignore the fact that the case fatality ratio is 60% here. That's because of case ascertainment. We didn't detect, we weren't testing effectively, we were only testing symptomatic people. In this phase of the pandemic, this is for care homes specifically, residents of care homes. So testing became better through 2020. We all lived through that, so we sort of understand. And then you get, it looks like the case fatality rate drops down. That's because there's a lot more testing, but that's PCR testing rather than LFD testing, so it's not instantaneous, it's testing infection rather than infectiousness. So so it looks like the case fatality rate's dropped. That's an artifact of the data. But then from here, you've got LFD testing. And so we can start to see trends. So we see the case fatality rate in care homes of about 20% through sort of the end of wild type and the start of alpha. And then it creeps up a little bit through alpha. We were sort of very eager, shall we say, that we have another lockdown at this point because we'd had Eat Out to Help Out, which sort of helped in various ways that were unhelpful. And then alpha had sort of come along, which was slightly more severe, potentially, if we believe this trend. And then you see the profound impact of vaccination. This drop down of halving is because we'd vaccinated care home workers and residents early, before the community. And then so vaccination sort of halved the case fatality rate. And then we've gone through about a year with a fixed, constant case fatality rate, and then Omicron snuck in, which was more transmissible. So actual total deaths, if we plotted total deaths, it was pretty much the same. The zero-sum game, but the case fatality rate for Omicron halved again, and that may not just be Omicron, that may be vaccine boosting effects. It's all very complex. But so more transmissible but less severe. One of the other projects that sort of supported us here was the PROTECT project, which was the national course. Full name was the National Core Study on Transmission and the Environment, and this was led by the Thomas Ashton Institute in Manchester. Lots of institutes and platforms being talked about today. But they're a partnership with the Health and Safety Executive, essentially. So the Health and Safety Executive were asked to lead this, and they commissioned Thomas Ashton to lead the research, coordinate the research. And so PROTECT offered a lot of concrete evidence, and as part of that, and as part of a MRC-funded gig worker project with Marty van Tongeren, we had a postdoc who's now a research fellow, Carl, look at the impact of LFD testing and whether LFD testing can be used to sort of stop disease coming in. And we can have fairly sophisticated mathematical models of the in-host dynamics of the viral load over time, looking at detectability. This isn't necessarily a very sophisticated model. Jing-Si, who's sort of sitting over there, has a more sophisticated model. But we then realised that the compliance was going to be a sort of a major factor, by which I mean probably technically that should be adherence rather than compliance, because compliance input sounds more negative, but do the people actually do the testing when they're told to do it? And there was some evidence from one employment sector, I won't go into which employment sectors, but one employment sector seemed to be more like 70% adherence, and another was more like 40%. So work needs to be done to engage with those sectors, to bring them through. And from a mathematical point of view, we're having to make assumptions about how that compliance, that behavioural aspect operates. Is it sort of leaky, or is it all or nothing? And so are people stubborn? Essentially what we're getting at here are people forgetful, or are people stubborn and refusing to do the test? And that can be like mathematically similar, but actually buried away in the assumptions there, important. I haven't really shown any models in these slides, but models are just an abstraction of the real world. We're making assumptions, we're generating a hypothetical mechanism, but we need help to generate that hypothetical mechanism, so we need to collaborate interdisciplinarily. Models are restricted by the availability of data, so we need to access data, and we need to know what data exists. That's a chicken and egg thing. We need to balance sort of accuracy of the models with transparency and flexibility. There's always going to be a compromise there. Without a model, you're guessing. So there's all the talk about whether we were too reliant on models through some of the press, through some of the pandemic. But without a model, what have you got? You just got a politician making a decision on a whim. Now, the model might be wrong. I'm not saying you still need to make sure your model, but at least you're reproducible, repeatable, and you're clear about your assumptions rather than just being, yeah. Sometimes it's better to have a simple model than a full-on simulation of everyone doing everything, so that you know the cause and effect that's going through. And yeah, there were a lot of people that contributed in various ways to the care home work that we did over the pandemic.